first speaker today is Dr. Seyyed Reza Sadat Ebrahimi from Tabriz University of Medical Sciences. Dr. Ebrahimi is a medical doctor and young researcher at Tabriz University of Medical Sciences. He have authored several papers in the field of cardiology, pharmacology, and neurology, and hold an issued patent of medical device at Intellectual Property of Iran, the Islamic Republic. Moreover, he have made several oral and poster presentation in some well-known conferences, including International Student Congress of Biomedical Sciences in Netherlands and International Congress of Cardiovascular Updates in Iran, and International Society for Evidence-Based Healthcare Congress in Iran. And he is the winner of Silver Medal of National Student Olympiad of Biomedical Sciences on 2018. He have cooperated with some of the research center of Tabriz University of Medical Sciences in conducting research projects and holding a number of international congress, including Research Development and Coordinator Center, Drug Applied Research Center, Research Center for Evidence-Based Medicine, Cardiovascular Research Center, and Neuroscience Research Center. His research interests are cardiovascular pharmacology and developmental of novel diagnostic and prognostic strategies for cardiovascular disease using biomarkers. The title of his talk today is The Clinical Utility of a VR Lead T-Wave in Electrocardiogram of Patients with ST Elevation Myocardial Infarction. Okay, Dr. Ebrahimi, please start. We are ready for you.
Hello, everyone. Thank you very much for your introduction, and thank you all for providing this opportunity for me to present my project. Let me share my screen. Okay, can you see my screen now?
Yes, we can see your screen.
Okay. The title of our project was Clinical Utility of T-Wave Amplitude in AVR Lead in Electrocardiogram of Patients with ST Elevation Myocardial Infarction. The main question of our project was that what is the clinical significance of T-wave amplitude in AVR lead in the admission electrocardiograms of the patients with ST elevation myocardial infarction? As you know, ST elevation myocardial infarction, I would like to abbreviate it as STEMI in the rest of my presentation, is characterized as one of the leading causes of mortality and morbidity worldwide. The 30-day mortality rate of STEMI is estimated to be up to 10% in developed countries, with the highest rates attributable to patients aged over, say, 75 years old or higher. 12 leads electrocardiogram, and I would like to abbreviate it in my presentation as EKG, is one of the most commonly used tools in the diagnosis and prognosis of STEMI. A variety of prognostic criteria based on the EKG findings in STEMI patients have been introduced so far. However, AVR lead is often neglected in routine clinical practice, largely because its undefined clinical utility specifications for a reliable prognosis and definite diagnosis of myocardial infarction. Nevertheless, the EKG parameters such as P-wave, QRS complex, ST segment, and T-wave in AVR lead are often characteristics in different conditions, and therefore correct interpretations of these changes are proposed to increase the accuracy of clinical diagnosis and prognosis. For instance, some studies have reported a significant association of ST segment changes in AVR lead but worse prognosis in patients with STEMI. Moreover, positive T-wave profile in AVR lead in patients with heart failure, old anterior myocardial infarction, and even in general population are reportedly associated with poor clinical outcome and considerably high cardiovascular mortality. As you can see in this paper, Okuda and his colleagues have demonstrated that as the peak T-wave amplitude in AVR lead becomes less negative, there was a progressive increase in mortality. Also in this paper, Shinzoki and his colleagues have reported that the positive T-wave in lead AVR is related to severely reduced cardiac function with an LAD wrapping the apex in anterior wall old MI. Also in this very interesting paper, you can see that Tian and his colleagues demonstrated that T-wave amplitude in lead AVR is a powerful prognostic marker for estimating risk of cardiovascular death. Therefore, in our study, we aim to evaluate the clinical utility of T-wave amplitude in AVR lead toward a better prediction of short and midterm outcomes of patients with acute STEMI. The design of our study was prospective observational study, and the location of our study was Tabriz Shahid Madani Cardiovascular Hospital. We included all adult patients with any gender with a definite STEMI diagnosis for the first time who were admitted to our hospital, Shahid Madani Cardiovascular Hospital, during the time period from April 2020 to September 2020. The diagnosis of STEMI was based on clinical symptoms and EKG changes and also lab results. The exclusion criteria were patients with atrial fibrillation or flutter, left ventricular hypertrophy, right or left bundle branch block, implanted pacemaker or defibrillator, or Wolff-Parkinson-White syndrome. These patients were excluded because these diseases can change the EKG and impose an additional EKG alterations and could mislead our project. The study population of our study was 410 patients at inclusion, but 70 patients were excluded due to the exclusion criteria that I mentioned in my previous slides. And finally, 340 patients were included in final analysis. Based on the admission EKG, we categorize patients into 4 strata. Patients, one strata was patients with a T-wave amplitude of higher than 0 millivoltage. The other group was patients with a T-wave amplitude between -1 to 0, and the next group was patients with -2 to -1 millivoltage, and the rest of the patients were categorized as those patients with T-wave amplitude of less than -2 millivoltage. We investigated the demographic characteristics, medical history, laboratory test results, EKG, electrocardiographic, and angiographic findings from our patients, and also we followed the patients for 6 months to evaluate our study's endpoints by performing telephone interviews, regular visits, or hospital reports evaluation. We also calculated the global registry of acute coronary events score for our patients. I will abbreviate this phrase as GRACE score in my presentation. Our study endpoints were, our primary endpoint was in hospital mortality, but we also investigated in hospital major events such as cardiac arrhythmias, as well as the duration of hospitalization. And also we investigated in follow-up the rehospitalization rate and 6 months mortality rate in our patients. The results of our study demonstrated that patients with positive T-wave, meaning that their T-wave amplitude was higher than 0, or they had a T-wave amplitude between 0 and -1. These patients, this group of patients, had worse clinical conditions. For example, they had significantly higher age. They had more frequently diabetes and hypertension. Also, they had more hypertriglyceridemia. Moreover, the serum creatinine of these patients was significantly higher than other groups, suggesting that these patients had a lower kidney function. Also, LV ejection fraction was significantly low in these patients. When we evaluated the study endpoints, we observed that the length of hospital stay was 7.5 in patients with 4.5 days, in patients with T-wave amplitude higher than 0, and a median of 6 days in patients with T-wave amplitude between 0 to -1. That was significantly higher than other groups. Also, the rate of VT and VF, ventricular tachycardia and ventricular fibrillation, was 20% in patients in this group, but 18 in patients with T-wave amplitude between 0 to -1. And these values were significant, but these values were higher than these groups, but the difference was not significant, statistically significant, I mean. But in hospital mortality was significantly higher in patients with positive T-wave, and those with T-wave between 0 and -1, as compared to patients with lower T-wave amplitudes. Also, 6 months cardiovascular mortality and hospitalization were considerably high in these groups compared to the other groups. So we calculated the relative risk, and we considered the group that had a T-wave amplitude between 0 and -1 as the control group. And we calculated the relative risk based on the result of this group. We can see that the relative risk were gradually increased by the increase in the T-wave amplitude. This was true for all 3 endpoints that we investigated, including 6 months cardiovascular mortality, rehospitalization, and in-hospital mortality. We can see in this figure that the GRACE score was gradually increased by the increase in the T-wave amplitude, and we found a significant correlation between these 2 variables, with a correlation coefficient of 0.35. We also investigated the determinants of T-wave amplitudes. We performed a multivariate regression analysis to assess that which variables can determine the amplitude of T-wave. And we found that LV ejection fraction, age, and heart rate were significantly associated with T-wave amplitude. In the next step, we evaluated the diagnostic and the prognostic discrimination power of T-wave amplitude in 3 different cutoff points. And we observed that in the cutoff point of 0 millivoltage, there were very high specificity for predicting 6 months cardiovascular mortality, in-hospital mortality, and rehospitalization. But there was very low sensitivity in this cutoff point. On the other side, in the cutoff point of -1 and -2, there was very high specificity. There was very high sensitivity, excuse me, but very low specificity, as you can see here and here. But we calculated Uden index for these 3 cutoff points, and we observed that highest Uden index was belonged to the cutoff point of -1. As comparison, we calculated the performance, the prognostic performance of GRACE score for our 3 endpoints, including 6 months cardiovascular mortality, in-hospital mortality, and rehospitalization. We observed that GRACE score at cutoff point of 141 had very high sensitivity and specificity. Also, it had very high sensitivity and specificity for predicting in-hospital mortality. So, in comparison, we can conclude that GRACE score was a very better tool for predicting the outcome of these patients as compared to T-wave amplitude. So, as conclusion, our study demonstrated a significant association of positive T-wave in AVR lead and risk of adverse clinical outcomes. Nevertheless, the prognostic value of T-wave amplitude at different cutoff points was limited by low discriminative potential, either low sensitivity or low specificity. Therefore, clinicians should be attentive to these markers and limitations upon the interpretation of AVR lead T-wave amplitude in ST elevation myocardial infarction patients. And the clinical judgment should not be based on merely T-wave amplitude. On the other side, the GRACE score serves as a useful add-on scale for risk assessment and determination of reasonable prognosis in STEMI patients. Our studies had also some limitations. For example, neither the invasive procedures nor provocative testing for ischemia or nuclear magnetic resonance imaging were conducted to validate the diagnosis and finding the affected myocardial. Also, to be more practical in interpretation of EKG records by the clinicians and to make it readily observable independently, especially in an emergency room situation, the smallest unit of T-wave amplitude change was considered as 1 millivoltage in our study. And we did not behave T-wave amplitude as a continuous variable. The clinical significance of our study was that Our study demonstrated a significant association of positive T wave in AVR lead and adverse clinical outcomes in STEMI patients. Nevertheless, the clinical utility of T wave amplitude at AVR lead is limited by its low discriminative potential toward prognosis of STEMI patients. Thank you very much for your attention. I would be more than happy to hear any questions.
Thank you so much, Dr. Ebrahimi. If anyone has any questions, please don't hesitate to ask. And of course, Dr. Ebrahimi's email address is mentioned in our chat box.